A Chance to Heal with Cold Hard Steel by Taylor Goodstein, MD. It's hard to explain what it feels like to someone who hasn't experienced it. The way your stomach drops like a lead weight. Down, down, down. And your hands betray you by shaking. Your body locks up while your lungs empty. Your heart vibrates against your rib cage. And as your brain races to make sense of what's happened, it shields you first with denial, just long enough to keep you upright, before catapulting you past bargaining, depression, and anger, and into something that passes as acceptance. Because there's no time to grieve, not yet. The beeping of the anesthesia machine brings you back into your body, reminds you that you are a surgeon. You are a surgeon, and you just made a huge mistake. You blink, your body reboots, and without ceremony, you begin the work of picking up the pieces. The patient was a young man, relatively speaking, in the urology world, and he came to us with a tumor eating its way through his pelvis. It had grown rapidly. Just weeks before, he'd been enjoying long bike rides and quiet, peaceful nights on the patio. He'd been mowing his lawn and taking his wife to dinner at the same restaurant every Saturday, where for the last 7 months or so, they practiced calling each other Grandma and Grandpa. When the pain started, he took some Tylenol and ignored it. Why let pain interrupt a beautiful life? But the pain deepened, and it wasn't long before he noted a melon-like protrusion blooming beneath his belly button. By the time he found his way to your clinic with a biopsy-confirmed sarcoma, the mass was so large and the pain was so great that he could no longer walk. A magnetic resonance image of the pelvis offered you and me a formal introduction to our foe. It was a mesenchymal mammoth, 20 centimeters in size, inextricable from prostate, bladder, rectum, and adjacent pelvic vasculature. It compressed L4, L5, and S1 nerve roots, the source of pain, no doubt, and spilled greedily out of its capsule, inching towards the pubic bone. It was a leviathan, but by all accounts, it was contained. Consistent with sarcoma, it had grown, but not metastasized. Whereas most cancers arise from the jam-packed hubbub of glands and linings, sarcoma is born in the deep and quiet roots of muscle, bone, and connective tissue. It's a malignancy of scaffolding, a cancer of substance. Thankfully, it's a rare tumor, but it's also a rebellious one, largely resistant to chemotherapy and radiation. All too often, the best and sometimes only option for treatment is to cut it out. A chance to heal with cold hard steel. And herein lies your dilemma, young surgeon, a dilemma that I, unburdened by the weight of this responsibility, am ill-equipped to help you solve. Here is a patient in debilitating pain with but one option for treatment. One option that you know is the epitome of a Hail Mary, a moonshot, an oncologic David versus Goliath. The number of complications that could happen during the surgery is just as long a list, if not longer, as the number of complications that could happen after it. It is less of a removal and more of a raising, requiring the excision of all pelvic organs, possibly even vessels and bone, followed by construction of outlets for urine and stool. Poetically, a surgical scorching of the earth. Technically, an exenteration. All of that is true, but so is this. If you do not, he will die. He will probably still die if you do. But only one of those options comes with that traitorous little spark: hope. Dim as it is, it's enough for the patient and his family, after hearing the laundry list of potential complications, no punches pulled, to want to proceed. You quickly give yourself a lifeline. We may get in there and find that it's not resectable, in which case we will abort the surgery. The patient and his family nod in grim understanding. Leading up to it, you battle with yourself. He knows the risks. He understands what could happen. Who am I to say no? I could relieve his pain. He could also die on the table, but he's going to die anyway. At least with this, he has a chance. But even if it all goes right, his cancer will probably come back, and then he'll die, just as he would have if I'd done nothing. It's enough to make you feel like a mere conductor, a director of this man's death, and the weight of that is impossible. so you turn the voices off. For the big day, you've made sure that you have me, your urologic oncology fellow, as your first assist. You've coordinated with a surgical oncologist to assist with the deeper pelvic dissection around the rectum. You've pored over the scan, talked to colleagues, and envisioned the steps that you need to take. You pray it will be enough. We enter his abdomen, are greeted mockingly by the tumor, and slowly, gingerly, we start to get the lay of the land. We release some adherent bowel, move it away, out of the mayhem, and start taking tentative little snips at the tumor, here and there, moving around it like a matador in a bull ring. Little by little, the same word begins to take shape in both our minds. Unspoken, unwelcome, and heavy with consequence. It is a dirty, painful, cacophonous word. It's the slamming of a door, the burning of a bridge. Unresectable. It's as obvious as it is painful, but you and I are stubborn, and we don't want to call it when the fight has hardly begun. So we press on, just a little further, just a couple more investigative nips and swipes, just so we can confirm what we already know. And it is during that interlude that, in a flood of dark, venous blood, all hell breaks loose. This was not the moment your stomach dropped. No, this was a problem to solve. We are professionals, and we did what we are trained to do. We packed a sponge against the bleeding to stem the tide while we fought for control. And eventually, we got it. The bleeding stopped. On the surface, a success. But that hemorrhage forced our hand, pushed us to continue a surgery we would have otherwise abandoned. Controlling the bleeding meant committing to the extirpation. As we carved the mass off the pelvic sidewall, it ruptured. Knowing what this meant, I did my best to keep that oozing maw of violent cells plugged with a sponge. A Sisyphean task. 6 hours later, we finally lifted it, kicking and screaming out of the patient and into a bucket. We stared into the gaping hole we'd hollowed, preparing to mop up any rogue bleeders. And that was the moment. The aorta, as you well know, ferries blood from the heart to the rest of the body. After arching out of the left ventricle, the aorta dives down, 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 until it splits into the common iliac arteries, which split again into the internal and external iliac arteries. The internal iliac arteries feed the pelvis and the organs within it. The external iliac arteries feed the legs. Eponymous veins hug these arteries closely, bringing dark, deoxygenated blood back to the heart. At some point in the operation, we had inadvertently removed his left external iliac artery and vein. Under the drapes, his left leg was cold and mottled. It's hard to explain what it feels like. Belly drops, hands shake, lungs slow down, and heart speeds up. It takes several seconds, marked out by the beeping metronome of the patient's own heartbeat. But eventually, we return to our bodies, ready to face the error we cannot undo. The vascular surgeon is called, and he uses Gore-Tex to graft a connection from the common iliac to the femoral artery, restoring flow to the patient's left leg. We complete the remaining steps of the surgery without further incident. After a night in the ICU, he wakes up with the ability to move and feel his leg and the absence of that gnawing pain in his belly. With the help of physical therapy, he walks. After several days, he goes home, grateful. On the surface, a success. But this is not a happy story. It is a cautionary tale. A Pyrrhic victory, made all the more painful because it brushed up against a happy story. It took a little over 2 months for the cancer to come back. Cackling, it exploded out of the nooks and crannies of his pelvis, choked off his bowel, filled his abdomen with putrid fluid, and gobbled through his energy stores until he was a shadow, sunken into bedsheets. The idea of chemotherapy was entertained, briefly, but he and his family quickly accepted that it was futile. After that, it did not take long for him to die. Looking back, it's hard to identify the one mistake. The accidental removal of critical blood vessels was the most obvious, the most actionable, but it was not the only one. In the innumerable conversations we've had since that day, including presentation of this case at M&M, one question has rang out louder than the others. Should we have operated in the first place? To many of our colleagues, the answer was a resounding no. You got lucky. That sort of deep pelvic bleeding can be impossible to stop. He could have died on the table. I have yet to see someone die on the table, but I'd imagine that the ground shakes and the walls crumble, and all the noise around you is replaced by loud, sharp ringing. It's hard to argue against the reasoning that you should avoid this at all costs. But then again, they never met him. Not like you did. They didn't see him buckled over in pain, desperation in his eyes. They didn't hand his wife tissues or look at photos of his pregnant daughter, or hear about his dream of making it to Italy one day. They didn't hug his family at the end of it all and cry together as he rattled out sharp breaths. And they certainly didn't know how much it meant to get 2 months free of pain and just enough time to meet his granddaughter. I'm still not sure what the right answer is. I know there are things we could have done better, ways we might have been more prepared, more precise, more perfect. I also know that in medicine, we tend to have very specific, rigid ways of defining success. In the traditional way of assessing survival in oncology, our treatment was an abject failure. But to one family, it was a windfall. It was the difference between regret and closure, between unrelenting agony and the first quiet breath of acceptance. It was an act of desperation, yes, but it was also an act of love, and something like that holds power that we cannot measure. A chance to heal with cold, hard steel, a classic surgeon's mantra, often recited with levity and pride. If only it were so simple. Like anyone in oncology, I'm intimately familiar with how often steel falls short of that goal. Complications arise, side effects linger, and cancer too often returns. But perhaps there's still something sacred in the act of trying, in the gesture of doing everything we can, even when the odds are long and the way is treacherous. After reflecting on this, I'm convinced that the key word is chance. It's a subtle admission, a quiet apology. Steel won't always heal. We wield it knowing that its edge can harm as much as help, and each time, we hope it delivers more than it takes. And when it does not, we grieve and find the courage to try again.
Welcome back to JCO's Cancer Stories, The Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm Professor of Medicine and Chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. Joining us today is Dr. Taylor Goodstein, Urologic Oncology Fellow at Emory University and our first Narrative Medicine Contest winner, to discuss her Journal of Clinical Oncology article, A Chance to Heal with Cold Hard Steel. Dr. Goodstein and I have agreed to address each other by first names. Taylor, thank you for contributing to the Journal of Clinical Oncology, to our contest, and for joining us to discuss your winning article.
Thank you so much for having me. This is a great honor.
The honor was ours, actually. We had, if you haven't heard, a very competitive contest. We had a total of 159 entries. We went through a couple of iterations of evaluating every entry to make it to our top 5, and then you were the winner. So thank you so much for contributing this outstanding essay, both to our Art of Oncology Narrative Medicine contest and also ultimately to JCO.
Oh, thank you so much.
So I was wondering if we could start by asking you to tell us something about yourself. Where are you from, and walk us through your career and how you made it to this point?
Well, I grew up in a small town in Colorado, called Glenwood Springs, Colorado. It's on the western slope, about 45 minutes north of Aspen. I went all the way to the East Coast for college, where I ended up minoring in creative writing. So writing has been a part of my medical journey kind of throughout. I went to medical school back in Colorado at University of Colorado in Aurora. And then I did my residency training at The Ohio State University in Columbus, Ohio. And now I am at Emory University for fellowship. And I've been kind of writing all throughout, trying to make sense of the various journeys we go on throughout the experiences we have with going through our medical training.
That's amazing. And I noticed how you emphasized the in Ohio State University.
Yeah, we fought hard. We fought hard for that B.
Right. Oh, as do we at the University of Miami. Yes.
Yeah.
What drew you to surgery and specifically surgical oncology?
My dad's a surgeon. My dad's an ear, nose, and throat doctor, and I am essentially him. We're the same person, and it made him very, very happy. So when I was looking at different medical specialties, I knew I was going to do a surgical subspecialty, and that's what I was drawn to. And then I was, looking for the one that felt right, ended up finding urology. And then throughout my residency journey, I really gravitated towards cancer care. I really loved the patient population, taking care of cancer patients. And surgically, it felt like a way that I was going to be engaged and challenged throughout my career, as there's so much that's always changing in oncology, almost too fast to keep up with all of it. But that's what really kind of ultimately drew me to that career path.
It's great that you had a role model in your dad as well to bring you into this field.
Well, he's very disappointed that I did urology rather than ENT, and he did private, and I'm going into academics. So, there's plenty of room for disappointment.
I'm sure the last thing in the world he is disappointed in you.
Yeah.
And I will say, so I'm able to see your background here. Our listeners, of course, are listening to a podcast and they're not. You have a very impressive bookshelf with a lot of different types of books on it.
This is your guys' background. This was then the option of one of the backgrounds I could choose for coming onto this. I didn't want to do my real background because I have a cat who's like wandering around and was going to be very distracting.
That's funny.
But I did like the books. The books felt like a good option for me. I do have a big bookshelf. Books are very important to me. I like to read. I don't do anything on Kindle. I like the paper and stuff like that. So I do have a big bookshelf.
There is something rewarding in the tactile field of actually turning a page of a book. You did writing from a very early stage as well. I was an English minor undergrad and then focused on creative writing as well and continued taking creative writing courses in medical school. Were you able to continue that during medical school and then in your training?
Yeah. I thought that's what I was going to do when I first went to college. Like, I thought I was going to be like a journalist or writer of some kind. And then I think maybe the crisis of job security hit me a little bit. And then also my desire to work with my hands and work with people. And I wanted something to write about, like something about my life that would be very interesting to kind of write about. And that sort of led me initially to medicine. But then, yes, to answer your question, I've been participating in a lot of writing competitions, like through the AUA, the American Urological Association. They do one every year that I've been doing in residency. And then in medical school, we had some electives that involved writing and medical literature that we did. There was a collection of student writings, a book that got published during my last year of medical school that I had a couple of essays in. And the journey changes over time. When you're a medical student, you're on this grand journey and you're so excited to be there. But at the same time, you feel so incredibly unprepared and useless in a lot of ways. You're just this medical student, the whole medical machinery is this well-oiled cogs rotating together. And you're just this wild little by yourself, just trying to fit in. And that experience really resonated with me. And then residency has its own things that you're trying to make sense of. I think it all pales in comparison to what it's like to kind of be a new surgeon for the first time, taking not necessarily obviously your first big case, but early in your career and having complications and making difficult decisions, I think, is one of the hardest things that we probably have to deal with.
Well, you write about this in an absolutely riveting way. When you and your fellow on this case with your attending, realize that in the mess of this aggressive tumor that you're trying to resect, you've removed the patient's external iliac artery and vein. You write, and I'm going to quote you now to you, which is always a little awkward, but I'm going to do it anyway. It's hard to explain what it feels like. Belly drops, hands shake, lungs slow down, and heart speeds up. It takes several seconds, marked out by the beeping metronome of the patient's own heartbeat. But eventually we return to our bodies, ready to face the error we cannot undo. As a reader, you're transported with you into that moment when, oh my God, you realize, what did we do? in this tremendous tumor resection you were undertaking. What was going through your mind at that moment?
This is going to sound maybe a little bit funny, but I always think about this line from Frozen 2. I don't know if you have any kids or you've seen Frozen 2.
I have kids and I've seen Frozen, but I have to admit I have not seen Frozen 2, and that's obviously lacking in my library of experiences.
Yeah, Frozen 2 is incredible, way better than Frozen 1. The adult themes in Frozen 2 go above and beyond anything in Frozen 1, but they're faced with some really big challenges, and one of the themes that happens in that movie is all you can do is the next right thing, and it gets said several times. I remember connecting to that when I saw the movie, and I've said it to myself like so many times in the OR since. You can't go backwards. You can't change what just happened. So all you can do is the next right thing. And so I think once the shock of what had happened kind of fades, all I'm thinking in my head is like, okay, what is the next right thing to do here? And obviously that was calling the vascular surgeon. And thankfully he was there and able to come in and do what needed to be done to restore flow to the patient's leg.
It's so interesting how we're able to compartmentalize in the moment our emotions. The way you write about this and the way you express yourself in this essay, you're horrified by what's happened. This is a terrible thing, yet you're able to separate yourself from that and move forward and just do the right thing for the patient at that time and get your patient out of this and yourself out of this situation.
I think that's honestly, and maybe not for everybody, but for me, that's been one of the challenges of becoming a surgeon is learning that level of emotional control, because all you want to do is cry and scream and like pull your hair out and like hit your fists against the table, but you can't do that. You have to remain in charge of that ship and keep things moving forward. And it's one of those hidden skills that you have to learn when you're going to be a surgeon that you don't get taught in medical school, and you kind of learn on the job in residency, but there's not as much explicit training that goes into that level of emotional control that you have to have. And I've kind of gone on my own self journey to get there. That's been very deliberate for me.
That's amazing. Do you think as we progress through our careers, and I don't want to use a term that's so dismissive, but maybe I'll try it anyway, that we become more nonchalant about surgeries or writing for chemotherapy or radiation therapy to deal with cancer? Or is that fear, that notion of with great power comes great responsibility, to loosely quote Spider-Man, is that always there? Do we always pause before we start the surgery, write for the chemotherapy or write for the radiation therapy and say, wait a second, what am I doing here?
I think it's always there. And I would argue that it even grows as you get farther along in your practice and you gain this collection of experiences that you have as a surgeon where you develop complications. And from that, you change your practice, you change the way you operate, the way you consider certain, operative characteristics. I would argue that as time goes on, you probably get more cautious approaching surgery for patients, more cautious considering the side effects of different treatment options that people have.
I think that's right. There is danger in reflecting on the anecdotes of your career experience to guide future treatments, but there is also some value to remembering those times when something went wrong or when it almost went wrong, and why we have to check ourselves before doing what may become routine at one point in our careers. And that routineness may be doing a surgery or writing for chemotherapy, but always remembering that there is great danger in what we're about to embark on.
Always, yeah.
Taylor, what makes this story really special, and one of the reasons it won our Art of Oncology Narrative Medicine contest, is just how deep you plunged into reflecting on this surgery. And you write, I'm going to quote you again, you reflect on how people may criticize you when you're attending for embarking on this surgery, but you say they never met him, not like you did. They didn't see him buckled over in pain, desperation in his eyes. They didn't hand his wife tissues or look at photos of his pregnant daughter or hear about his dream of making it to Italy one day. They didn't hug his family at the end of it all and cry together as he rattled out sharp breaths. And they certainly didn't know how much it meant to get 2 months free of pain and just enough time to meet his granddaughter. There's a hard truth. You write it just perfectly. There is a hard truth to why we don't always follow CMS guidelines for not offering treatment at the end of life, isn't there?
Yeah. Yeah, it's tough. And, I think a lot about this because I've heard a few times like to be cautious of the armchair quarterback, specifically when you're talking about M&Ms. It's so easy to come in at the other side of a bad outcome and talk about how, you should have done this, you should have done that. And to be fair, during that M&M in question, as I think back to it, the feedback for the most part was very constructive and, ways to maybe be more prepared coming into a surgery like this. Like there were questions about whether here at Emory, we operate over various different hospitals of like whether the hospital, it should have been done at an even different hospital was like one of the questions that maybe had more resources. So things like that. But it is hard, I think, when you get that question, like maybe you shouldn't have operated. And, I think one of the lessons I learned here is being unresectable doesn't mean you can't resect the tumor. We say the word unresectable, like we resected it, but what was the cost of that? Obviously, like we can resect a lot of things, but how much collateral gets damaged in the process of doing that? However, it's a very challenging question. I mean, this guy had one option, really. I mean, chemo wasn't going to work, radiation wasn't going to work, and his goals were different than our goals are necessarily when we talk about cancer care. He wanted to be free of pain. He wanted to be able to go home. He was admitted to the hospital. He was on an IV, like Dilaudid, like he could not get off of a PCA because of how much pain he was in. And he just wanted to go home and be there for the birth of his granddaughter. And that's what we tried to do for him, in which case we were successful, but in everything else, we were not.
And you were successful. I could imagine that was, when people are in pain, their immediate goal, of course, is to get rid of the pain. Being in pain is an awful place to be. But with the impending birth of his granddaughter, I have to imagine you realign what your goals are, and that must have been primary for him, and you got him there.
We did. I also, I did talk a little bit about this later on, is like this idea of providing peace for families. I think that there's this sense of maybe peace and acceptance that comes from having tried to do the long shot surgery, that if you had never tried, if you come to them right away and you say, oh, I can guarantee that this isn't going to ultimately end up well, there's still like that, like what's going to linger in the back of their mind if it never gets attempted versus, okay, we tried, it failed, and now we can come with this almost like satisfaction or comfort knowing that we did everything we could. And so I guess I think a little bit about that as well.
I think that's a beautiful place to end this as well. There are so many factors we have to consider when we embark on this cancer journey with our patients and when we make recommendations for treatment. And it sounds like, and it is so beautifully reflected in your essay, that you thought extremely holistically about this patient and what his goals were, and appreciated that those goals had to be severely modified once he had his cancer diagnosis.
I think the most important sentence is, I still don't know what the right answer is. And I think that's important for me to end on.
Well, and you're still in training. I think it's so important to acknowledge that when you're training. It's important to acknowledge it when you're at my stage of my career as well. There are still encounters where I come out and I think to myself, I'm still not 100% sure what the right thing to do is. But often we let our patients guide us and we let their goals guide us. And then we know that at least it's right for that person.
Yeah, exactly.
Well, it has been such a pleasure to have Dr. Taylor Goodstein, who is a fellow at Emory University, to discuss her outstanding essay, A Chance to Heal with Cold Hard Steel. Taylor, thank you so much for submitting your entry to our first Art of Oncology Narrative Medicine contest, for winning it, and for joining us today.
Thank you so much for having me.
If you've enjoyed this episode, consider sharing it with a friend or colleague, or leave us a review. Your feedback and support help us continue to have these important conversations. If you're looking for more episodes in context, follow our show on Apple, Spotify, or wherever you listen, and explore more from ASCO at asco.org/podcasts. Until next time, this has been Mikkael Sekeres for JCO Cancer Stories, the Art of Oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.